This video is on the basics of ventilators plus a little more. Here we will review the indications for mechanical ventilation. We'll cover the basics of normal lungs, that is ventilation and oxygenation and compliance. We will also cover vent settings in this video. Vent types, pressure, volume control, and the inspiratory hold maneuver will be discussed in part 2. So to review, the two major functions of the lungs are ventilation, which is the process of expelling CO2 out, and oxygenation, which is getting oxygen into the blood. When ventilation fails, we get hypercarbia, and when oxygenation fails, we get hypoxia. These both are indications for mechanical ventilation, but we can also have cases where the lungs are healthy, but other organs aren't working properly. For example, in neurological disorders where the respiratory drive is impaired, and in cardiac dysfunction, where the heart fails to pump oxygenated blood to the body, driving the lungs to work extra hard and eventually tire out. Let's take a closer look at ventilation. You need to be familiar with the equation for minute ventilation, which is the tidal volume times the respiratory rate. So when we talk about hyperventilation, we are expelling more CO2 than the body is producing. This can happen if there is an increase in respiratory rate with normal tidal volumes. You may be familiar that tachypnea is a sign of pneumonia. This occurs because the inflammation in the lungs prevents alveolar expansion, and so we get smaller tidal volumes. But to maintain minute ventilation, respiratory will go up as a compensatory mechanism. To sum up, ventilation relies on tidal volume and respiratory rate, while oxygenation relies on FiO2, which is just the concentration of oxygen being delivered. And you might think, why not deliver 100% oxygen? And the answer is that too high concentrations can produce reactive oxygen species, which can damage the alveoli, so we need to be careful. Oxygenation also depends on PEEP, or positive end expiratory pressure. Real quick, let's review PEEP. So here we have a pressure graph, and we are dissecting a single breath with inspiration and then expiration. In a normal alveolus, the pressure starts at 0, becomes negative on inspiration when the chest wall expands so that air flows in, and the walls of the alveolus clamp down, making the pressure positive now, so air moves out and the alveolus returns to a pressure of 0. So at the end of expiration, normally we have 0 end expiratory pressure, or ZEEP. A PEEP of 5 means that the alveolus pressure at the end of expiration is 5, and the respiratory cycle still cycles normally, but the alveolus is kept at positive pressures. This is helpful in ventilated patients for a few reasons. PEEP helps recruit more alveoli available for oxygenation. In the healthy lungs, this could open reserve alveoli, and in the diseased lung, it can open atelectatic alveoli. PEEP also decreases the work of breathing because it's easier to open an alveolus that's already open by Laplace's law. The downside of PEEP is that it creates a positive pressure in the thorax, and since venous return flows from high to low pressures, this can be bad. Because of the higher pressure in the thorax, you can get lower venous return and therefore decreased cardiac output, so we need to be careful. The last concept we need to understand before getting to vents is compliance. Compliance is how stretchy the alveoli are and how easily the lung can inflate with a given pressure. We have two rubber bands here that represent two different lungs. The top one has more elastic fibers, so it's got a greater elastance and will snap back much more quickly than the bottom one. Since compliance and elastance are inversely related, the top rubber band has a lower compliance than the bottom one, which has a higher compliance. Let's apply the same pressure to test their stretch. We see that the bottom one with higher compliance immediately stretched out and the top one is struggling. So we add more pressure and keep adding more pressure and more pressure to get it to stretch the same distance as the bottom one. So we really see that compliance is how much change in volume we get for a given change in pressure. And the take-home message is that high pressures are required to open a low compliance lung. So what makes a lung have low compliance? We have decreased lung compliance because of issues in the parenchyma or alveoli, like decreased surfactant, pulmonary edema, pulmonary fibrosis, atelectasis, or problems in the airway like obstruction. We can also have decreased chest wall compliance because of problems in the bone, like scoliosis, in the muscle from certain medications, or pleural cavity from fluid or air in that space. Another thing to consider is diaphragmatic restriction, and a good bowel regimen can prevent constipation, which can cause abdominal distension and prevent the lungs from expanding. Now let's review vent settings, which you will need to know how to report. We talked about tidal volume and respiratory rate being factors of ventilation. Tidal volume is based on weight, and so it's reported as milliliters per kilogram. Respiratory rate, on the other hand, is set based on age. FiO2 and PEEP are factors of oxygenation. We should also report the pressure support. To understand what this is, let's clear the board and look at this baby on a ventilator. The trachea and bronchi represent physiological dead space because they do not participate in air exchange. The vent tubing is basically an extension of the trachea, so it's extra dead space. It's the same concept as if the normal trachea were extended and we had extra dead space. So the pressure support provides extra pressures to overcome the resistance in the extra dead space from the tubing, and this actually increases patient comfort. While we have this baby on the ventilator, let's talk about oxygen bleed-in. Here, the patient is receiving 21% FiO2 from the vent, but this ventilator has a special opening for another oxygen source from the wall. So the actual FiO2 that the patient experiences is higher than the vent setting, and in this case, 28%. Now, one more measure of breaths is the inspiratory time, or I time. This is the time taken for inspiration of one breath. To calculate this, we are given a respiratory rate of 20 and an I to E ratio of 1 to 2. For those of you who don't know, the I to E ratio is the inspiration time to expiration time of one breath, and a normal ratio is 1 to 2. So you normally spend twice the amount of time in expiration than in inspiration. A respiratory rate of 20 breaths per minute equates to 60 seconds for 20 breaths, which simplifies to 3 seconds per breath. And with our I to E of 1 to 2, we see that inspiratory time is 1 second and expiratory time is 2 seconds. So this slide sums up the vent settings that we just discussed, and we will continue our vent talk in the next video.